Yep, let's get started. I'm going to be talking about monkeypox today, and my content experts are Megan Wimmer and Jill Strayer. So some objectives to today is going to be to summarize symptoms associated with monkeypox, explain the diagnosis criteria for monkeypox, develop a treatment plan for symptomatic patients, and evaluate when vaccine prophylaxis is indicated. So let's dive in. As you can see here, monkeypox virus is closely related to the variola virus, which is also known as smallpox. All viruses listed in the orthopox virus genus are approximately 96% share approximately 96% of genomes in their central regions and then differ in the terminal regions. The ones that can cause human infection are monkeypox, Vaccinia, which is right under variola, and variola along with cowpox. What makes monkeypox different than smallpox is that it's primarily caused by the monkeypox virus. It has two different strains, known as the West African and the Congo-Basin strain. The Congo-Basin strain has been known to have more morbidity and mortality with more human-to-human transmission. The strain primarily circulating the US is the West African strain, which is less severe. Reservoirs for each of these viruses is different, with smallpox primarily found in humans only, while monkeypox has made its way to humans. Fatality is more common in smallpox at 30 to 50% compared to monkeypox at 1 to 10% of cases. And then due to the elevated fatality rate for smallpox, everyone was getting vaccinated for smallpox up until 1972. The vaccination recommendation was stopped due to the disease being eradicated from the US. Patients born before 1972, if they had any known risk factors, were recommended to be, or if they had risk factors, were recommended to be vaccinated against smallpox. It is also possible that there was a loss of immunity against smallpox over time, combined with other factors to increase sporadic cases and outbreaks globally in the past 15 years. So then I want to dive into some virology to also understand the kind of like background knowledge. Monkeypox is a zoonotic virus, meaning it infects a wide range of animals, including rodents, insects, birds, reptiles, and mammals. It's originally discovered in Africa. Monkeypox is endemic to the tropical rainforests of the West and Central Africa regions. Monkeypox was also discovered in 1958 in a non-human primate. It was found specifically from an outbreak in research monkeys, which is how it got the name monkeypox. The first human case was discovered in 1970, causing sporadic outbreaks in the African countries. And then for transmission, it is believed to be primarily in rodents initially, due to the virus being isolated from several animal species. There have been animal to human transmission through bites and scratches. However, the definitive animal reservoir has not officially been identified. The virus itself on a molecular level is a large enveloped and brick-shaped virus. It's encapsulated with double-stranded DNA genome and enzymes required for viral encoding and replication. It invades a human host cell in the cytoplasm. The virus encodes a large number of protein for synthesis of virus mRNAs, and then the replication of virus DNA and assembly for complex virions. Specifically, it replicates in the cell involved in regulation of the virus with both individual cells and the host organism. So overall, orthopox virus, that genus, are cross-reactive between the virus and the host and cross-protective when replicating, providing the virus overall stronger protection for continued growth. So it will start to infect typically in the oropharyngeal or respiratory mucosa and then circulate through the lymph nodes and draining mucosa. However, compared to smallpox, monkeypox does have that lower human-to-human transmission and lower death rates, which is why monkeypox has not previously caused expanded epidemics. And here are the current numbers of monkeypox cases utilizing WHO statistics reported since January 2022 this year, all the way to August 24th of this year. And you can see here that the Americas currently have over 22,000 cases. European region has over 21,000 cases, and the US alone has over 15,000 cases of monkeypox. When we break it down by state, you can see here, this is a map of monkeypox cases as of September 14th of 2022. You can see here also that California has overall 4,300 cases, and it just says over 500 here. But then New York is like a dark blue, indicating that there are over 500 cases too, and they're sitting at 3,679. Florida over 2,000, Texas over 2,000. Illinois is over 1,000 cases of monkeypox, and then Minnesota is at 163. For us in Wisconsin, we're sitting at 64 cases. And then previously, transmission for monkeypox was in West Africa was predictable because monkeypox was an endemic. Being an endemic means the outbreak localized to the West Africa region where the disease has been consistently present, but in a particular region, we were able to predict where the disease would spread to. However, as we travel to and from these endemic places, and with the lack of immunity from smallpox vaccines, we can cause an epidemic or a non-endemic outbreak of the disease to affect other populations rapidly in a different geographic location. Our focus today will be on the non-endemic spread into our communities. So then monkeypox can be transmitted in two kind of main pathways. The first pathway is primary transmission from animal to humans. This typically occurs with bites, scratches, consumption of infected animals, mucous membranes, and blood. Incubation period for both of these is typically 7 to 14 days. Secondary transmission, which is more kind of what we're dealing with now, is human to human transmission between broken skin or direct physical contact with infectious fluid or lesions, respiratory tract, which is close, prolonged face-to-face contact. This usually occurs through large respiratory droplets and not typically aerosolized droplets that was seen with COVID. So you can see in this image to the right here, there's a droplet versus airborne. This is primarily through droplet transmission. Mucous membranes are also a way for human-human transmission too, along with contaminated objects and surfaces. I try to figure out how long, it just says prolonged duration of respiratory droplets, but exactly how long is that? And I could not find any clear information on how long that is, unfortunately. And then again, incubation period is typically 7 to 14 days. And this leads to my first objective, which is to summarize the symptoms associated with monkeypox. So symptoms, most people, at about 100% of patients who have monkeypox, have exhibited a rash. And this is typically at onset of illness. The rash is found in the arm, perianal, or genital areas. Other symptoms include fatigue, chills, lymphadenopathy, headache, fever, and then there's also body aches, sore throat, or cough too. Most symptoms other than rash occur during the prodrome phase after incubation, because this is due to the virus traveling through the lymph nodes causing these systemic symptoms. After these systemic symptoms, then the chronic rash typically develops. The typical course of a rash will occur and be primarily in the mouth and spread to the face and extremities, including palms, arms, and soles. There are different phases to the rash development. We've got the macular phase, which is discoloration of the skin. This is actually the most contagious phase. Although all these phases are contagious, you are contagious during all of the steps here. We've got the papular, which is a nodule elevation of the skin, and then the vesicular phase, which are blisters containing clear fluid, pustules that are elevations with pus, and then it scabs over. And these symptoms typically resolve between 2 to 4 weeks, sometimes even longer. Then leading to the next objective, let's think about the diagnosis criteria, because it becomes an important role in deciding when to test someone for monkeypox versus not. There are two main things to consider when diagnosing a patient for monkeypox. We've got clinical manifestations or clinical diagnosis and laboratory diagnosis. There are three components to a clinical diagnosis we need to consider. We've got travel history, contact risk factors, and a skin rash. Let's break down what each of these mean. So travel history, this is when traveling within a few weeks into an area with high numbers of monkeypox cases. So knowing where monkeypox cases are high are a vital part for understanding clinical diagnosis, along with contact history, including closer physical contact with a person who has suspected or confirmed monkeypox, and physical or sexual contact. This is especially higher with men who have sex with men or sexual contact during travel. Skin rash is also a characteristic for clinical diagnosis. So if a patient presents with a characteristic monkeypox skin rash, that is also a sign of a clinical diagnosis. Again, if you have any of these three signs or symptoms, then it is recommended to test the patient for monkeypox and it is likely that they have a clinical diagnosis pointing toward monkeypox. This does not mean they are officially a confirmed monkeypox diagnosis yet, though, which leads to the next part of the diagnosis criteria of laboratory testing. So here are two tests available here for monkeypox. The two tests available are the PCR, or the polymerase chain reaction, and an immunoglobulin antibody assay. For the PCR, it specifically detects DNA polymerase gene called Copenhagen, or COP, specifically the B5R gene. And this is specific to the monkeypox or orthopox viruses overall. It's only valid to diagnose monkeypox acute infections, but not after the infection has cleared. Sensitivity of the PCR is approximately 95 to 98%. Immunoglobulin antibody assay can consider obtaining an IgG or an IgM assay to detect if a patient has been recently or previously been infected with monkeypox, but it's only used for quantitative virus interpretation. It's not really valuable for acute diagnosis, and this lab is a send out, and it takes approximately 1 to 2 weeks to return. And then ARUP lab does have the orthopox PCR virus detection, or PCRs available. Specifically can detect orthopox virus with a lesion swab with a turnaround time of about 1 to 3 days. And this lab is a send out lab to the state lab of hygiene and report it back to HealthLink with a call from the state lab to the provider who ordered it. The State Lab of Hygiene is located in Madison, but there are other labs that are capable of running the test too now. Do note that this lab will detect all orthopox viruses, including the non-variola strains, such as monkeypox. In certain situations where there is a high viral titer of the variola virus, and again, variola virus is smallpox virus, it can result in a positive test and affect interpretation of this result. Bringing it back to kind of the original diagram, once we have a clinical diagnosis and laboratory diagnosis, then a patient can be confirmed as officially monkeypox. So let's pause and do a case real quick. This is Ted Mosby. He recently attended a Renaissance fair in Central Park in New York a few weeks ago, where he had multiple sexual partners. He developed a rash on his right arm with no other symptoms. He read online about monkeypox and wants to be evaluated for it. The providers consult you to see if he's eligible for treatment. What do you recommend? We've got A, test for monkeypox, B, treat with antiviral therapy, C, treat Ted with antiviral therapy and give him the smallpox vaccine, or D, tell Ted this is not monkeypox and discharge him. You could put your answers in the chat box. That would be great. And I'm seeing some answers in the A's. And yes, I agree with you all. The answer is A. We want to test Ted for monkeypox. He has that typical lesion or the skin rash that we expect, but he doesn't have an official diagnosis for monkeypox. So we want to get a laboratory diagnosis with a test. Leading to objective number 3, develop a treatment plan for symptomatic patients. So always first recommend supportive cares for symptom treatment. For a rash, you can use topical lidocaine or corticosteroid products. For fatigue, chills, headache, fever, or body aches, we recommend Tylenol or ibuprofen. And for sore throat, cough, you can recommend some cough suppressants, mucolytics, or oral numbing spray to help. Note that most of these products are available over the counter at your local outpatient pharmacies. And now we'll dive deeper into the fun stuff, the antivirals. We've got Tecovirimat, Cidofovir, and Brincidofovir. We'll start with Tecovirimat. The brand name is Tpox, so you may hear people saying Tpox because it's easier to say. It's originally made for treatment for smallpox. The mechanism of Tecovirimat is It's an inhibitor of orthopox VP37 envelope wrapping protein specific to orthopox viruses. A major limitation we have is that a lot of the studies, are not performed in a well-controlled human trial, has not been feasible. And it's also unethical to induce smallpox disease in humans to study the drug's efficacy. So how do we know it works? In 2008, there was a study which performed 3 different independent assays to assess the in vitro efficacy of Tecovirimat to smallpox and monkeypox virus. To the left, you can see the different strains of the variola versus monkeypox viruses infected in the wells. Each well contains a different concentration of Tecovirimat noted at the top. You can see in the picture here that there are plaque formations in the assay. The plaques reduce in size uniformly between both the smallpox and monkeypox virus. There was a notable reduction of plaque size at the concentration box there at 0.05 micromoles. Overall, found that the assays blocked the formation and release of envelope virions. This means that the mechanism of action is similar in both the smallpox and monkeypox virus. Later on, models of orthopox virus disease were developed in mice, squirrel, rabbit, and monkeys. In 2010, this review discussed safety and efficacy of Tecovirimat and found it overall to be effective at 100% efficacy against orthopox viruses, and looked specifically at monkeypox and found 100% efficacy. Safety profiles found it to be generally safe with no chromosomal damage or bone marrow toxicity. More down the road, there was a 2018 safety and efficacy trial of oral Tecovirimat on non-human primates and rabbits inoculated with smallpox or rabbitpox virus. A variable number of doses ranging from 0 to 10 milligrams per kilogram for non-human primates and doses from 0 to 120 milligrams per kilogram from rabbits were used to evaluate efficacy. On the graph to the left, we look at the results of the variable doses for a non-human primate and found that the optimal dose was approximately 3 to 10 milligrams per kilogram, which is that yellow line. However, in the graph to the right, we see here in rabbits, we found that the optimal dose was 20 milligrams per kilogram, which is that green or blue line on the top. So then we extracted the dosing data and went with the conservative dosing from the non-human primates of 3 to 10 milligrams per kilogram. This study also was great because it looked at so many different things too. It looked at the pharmacokinetic profile of Tecovirimat utilizing 10 milligrams per kilogram dosing or 600 milligrams by mouth twice daily, and found that taking it with food increased the concentrations of Tecovirimat. You can see here the blue line is taking Tecovirimat with food, which achieve higher concentration levels. The same study, again, also looked at the effectiveness if treatment was delayed. A dose of 10 milligrams per kilogram for non-human primates initiated at 4 to 5 days after exposure showed a survival rate of 83.3% on day 6. 83.3%. On day 6, the survival rate reduced to 50%. This further shows that the medication is most effective when initiated within 4 to 5 days of exposure in an ideal scenario. In the same 2018 expanded safety trial for oral Tecovirimat, 359 patients received oral Tecovirimat and 90 patients received placebos. Adverse events were reported in over 2% of healthy adults, who reported primarily headache, nausea, abdominal pain, and vomiting as the most commonly reported side effects. Looking at the safety effects of IV Tecovirimat, they also looked at 26 patients who received IV Tecovirimat and 6 patients who received placebo. Adverse events were reported in over 4% of healthy adults, which were specifically infusion site reactions. Interestingly, though, note that approximately 2/3 of patients receiving the placebo also had infusion site reactions. And I could not figure out why, unfortunately. Overall, though, this data here is showing that this medication is safe and well tolerated by patients, especially the oral capsules. Now that you know more about Tecovirimat, kind of like how it developed, here are the doses and the medication for the medications, which is weight-based. It comes as IV and a PO formulations. The oral capsules must be taken within 30 minutes after a moderate or high-fat meal for best absorption. For children, you may consider opening the capsules to be given with semi-solid food. The doses of these open capsules do vary, which is listed down there. There are no renal adjustments needed per the package insert. And then notable drug interactions also include the following. It is a weak CYP3A4 inducer and a weak CYP2C8 and CYP2C19 inhibitor. Repaglinide, which is a meglitinide used to lower blood sugars, this will cause an increase in serum concentration of repaglinide. So close monitoring for hypoglycemia is recommended. Rilpivirine, Derivirine, which going back to your HIV notes is an NNRTI, along with Maraviroc, which is an HIV entry and fusion inhibitor. These medications will cause a decrease in concentration because of the CYP3A4 induction. It's important to consider a dose increase for the duration of Tecovirimat and for 2 weeks after completion, or consider avoiding the combination if possible. So to kind of stop a little bit and summarize Tecovirimat before moving on, here are some main points. Tecovirimat is an effective regimen for treatment of monkeypox virus infection. Initiation of Tecovirimat within 4 to 5 days is ideal for the best chance at survival. And then both the oral and IV formulations have mild to moderate side effects, which are tolerable for overall healthy individuals. So now we know Tecovirimat is safe and effective. Where does it play in therapy? Here is the EUA criteria, from the FDA. There are 2 different considerations. Primary or early empiric treatment is indicated if you meet any of the following: laboratory confirmed monkeypox virus and or severe clinical manifestations. And this is typically if they have hemorrhagic confluent lesions, sepsis, and some patients have had encephalitis too. And then, or if initial negative monkeypox test was negative, but epidemiologic and clinical evidence suggests monkeypox infection, especially if they start to clinically worsen. The EUA actually recommends you to treat with Tecovirimat while results are pending and to retest. And if the test is negative, again, stop, but if it's positive, continue treatment. And this is due to sometimes the PCR may not be at it, or the viral load might not be at a detectable level, which is why it might initially result as negative. And that's important. That's why it's important to retest and to get that definitive answer. Secondary treatment indicated in any of the following for complications of monkeypox virus from vaccination, secondary transmission, or other exposure. So this is where if you've had contact with another person who got a live vaccine and developed a serious reaction to it, which we'll talk more about later. And then if a patient is not eligible for the vaccine immune globulin treatment too. So overall, Tecovirimat is recommended by the CDC right now as first-line therapy for treatment of severe monkeypox infections or patients at risk for developing severe monkeypox disease. Unfortunately, obtaining Tecovirimat is a complicated and lengthy process. The CDC obtained expanded access investigational new drug, or IND, authorization by the FDA to allow Tecovirimat to be used for non-smallpox orthopox infections. So this is a big deal because it does not require clinicians and facilities to necessarily obtain their own INDs for Tecovirimat. It is available through the Strategic National Stockpile managed by the CDC. This is essentially a part of the federal medical response in a scenario like this, where a public health emergency is severe enough to cause supplies to wipe out in local areas. Clinicians who suspect monkeypox is in a patient should immediately first contact the DHS Bureau of Communicable Diseases to discuss whether testing or other public health actions are indicated. Phone number is listed there. A medical provider, it must be an MD or DO. They must fill out the 3 forms listed here as primary investigator. Unfortunately, we cannot have mid-levels fill out these forms. This is only specific to Tecovirimat and may not apply to other medications. So then one of the forms is called the informed consent form, which is to get patient's consent. And then we've got another form, the patient intake form, and it's to allow the CDC to review the patient's baseline assessment for Tecovirimat, and then to fill out FDA form 1572 and provide a clinician CV. This form is required to be filled for any investigational drug use. And given this medication is under expanded access IND, it's required. So in the state of Wisconsin, it is required that these forms all be filled out and then sent to the DHS Bureau of Communicable Diseases. Once DHS Communicable Diseases will send this out to the CDC to request for the medication on our behalf. So once we fill out the forms and send it out, our lovely PRC team will receive the medication and coordinate delivery to the patient. Cidofovir, now shifting gears to cidofovir, this is the next medication. We've got, it's an acyclic nucleoside phosphate discovered in 1986 with broad activity against several DNA viruses by inhibiting viral DNA synthesis and polymerases. It does have poor oral availability, so it is given as IV only. And it's originally formed as cytomegalovirus retinitis treatment agent, or CMV retinitis, in patients specifically with AIDS. No human studies currently exist to prove the effectiveness of cidofovir in humans with monkeypox, but it is proven to be effective against orthopox viruses again in vitro animal studies. So the CDC listed this as a treatment option. Why? Let's talk about that. In 2010, there was a review that discussed the in vitro efficacy against orthopox viruses by looking at reducing viral replication. This review discussed the medication and similar proposed molecular structures by their molecular scientific names. This review found that cidofovir had efficacy against several numbers of orthopox viruses along with other viruses in the same family. It looked at different effective concentrations used to reduce several virus cytopathic effects by 50% and found cidofovir, which is boxed here as SHPMPC, that had activity against Vaccinia virus, which is VACV. Overall, this medication was studied in vitro for Vaccinia virus, which is similar to monkeypox, and then extrapolated for treatment for monkeypox based on this data. The study concluded it may be efficacious for treatment of several orthopox viruses. In 2008, there was a review that looked at the efficacy of cidofovir in animal models against smallpox virus. Looked specifically at studies performed between the years of 1950 to 2002 in mice, rabbits, and monkeys who were infected with a variety of orthopox virus. Side effects that occurred during these studies were nephrotoxicity. So efficacy data on in vivo is what I have here, unfortunately. This review article did find that it was efficacious, and side effect profile overall calls it generally safe with nephrotoxicity as it's concerned. The CDC recommends we use cidofovir only when Tecovirimat is unavailable. Unfortunately, this is the limited data we have for the treatment for cidofovir specifically for treatment for smallpox, which is why we're not using it specifically as first-line therapy. And here's a nice table to highlight the important points to cidofovir again. For your reference, I just want to mainly point out that the medication is very nephrotoxic, that occurs in about 59% of patients who receive cidofovir as a maintenance medication. It's important to hydrate with that 1 liter of saline over 1 to 2 hours prior to the infusion. It is contraindicated to use in patients with serum creatinine over 1.5 milligrams per deciliter, creatinine clearance of under 55 milliliters per minute, or if they have a urine protein of over 100. And then UW does have intravenous administration guidelines for cidofovir too, and we do make a note for that hydration of 1 liter of saline prior to the infusion too, along with monitoring effects to be on the lookout for. And then in summary, to kind of wrap up cidofovir, in vitro studies show that cidofovir has activity against many different types of orthopox viruses, which includes monkeypox virus. And cidofovir is nephrotoxic. Appropriate hydration is necessary to prevent nephrotoxicity. So switching gears to the next medication, which is brincidofovir. This is essentially cidofovir with a lipid side chain to allow rapid passive diffusion into the cell. Once inside the cell, the lipid side chain will release cidofovir and prevent DNA viral replication. So brincidofovir is used for treatment in human smallpox disease, but nothing is available for smallpox infection specifically right now. Using the same studies, brincidofovir is also found to be effective against orthopox virus in vitro animal studies. For example, smallpox, in a smallpox safety study, we looked at 392 patients who received brincidofovir 200 milligrams once weekly for 2 weeks, and side effects reported in it had at least 2% of were reported in 2% of subjects. It only looked at what side effects that occurred during the first 2 weeks of treatment. These side effects are primarily GI side effects. Interestingly, when I was trying to look at how much nephrotoxicity was reduced. Wasn't able to find any specific data on by how much, because cidofovir was about almost 60% of patients got nephrotoxicity. Couldn't find any, but I found 2 case reports where transplant patients using brincidofovir for CMV treatment, both there were 2 cases where they each had nephrotoxicity, and once the medication was withdrawn, their serum creatinine drastically improved. There's 1 patient that did re-challenge brincidofovir after that, and their serum creatinine jumped up right away after a month. And then as soon as that medication was discontinued, it dropped back down too. So I don't have a definitive answer, but it sounds like with post-marketing kind of data, it sounds like there's been nephrotoxicity reported with brincidofovir. Efficacy was not completed again, similar to before. Studies in a well-controlled trial is not feasible for smallpox or monkeypox, and it's also unethical to induce smallpox disease in humans to study the drug's efficacy. So we looked at the efficacy for the raw data for brincidofovir, and there was a study in 2021 that looked at the percentage of survival when giving brincidofovir to prairie dogs infected with monkeypox virus. 28 subjects were infected with the virus, and a total of 50% of survival rate was observed for the prairie dogs treatment was initiated a day before being infected with the virus, and then 43% survival when treating on the day of infection, and then 29% for survival rate 1 day after infection, and then 14% survival rate in the placebo group. There was no statistical significance, but you can see here that there's an overall trend of protection with brincidofovir against the virus, suggesting it is an effective treatment option, possibly for monkeypox. So then here's a table again to kind of, for your reference, about some kind of those dosing nuances. There are some administration and consulting points to discuss though. Patients will need to take this medication on an empty stomach for best efficacy. If patients do have those GI side effects, you may consider administering the medication with a low-fat meal. Overall, this medication is a great medication with less toxicity, but do note that this medication is not available in the US yet. So then to kind of summarize brincidofovir, we've got brincidofovir is effective in delaying mortality from complications from the virus, shown in animal models. It is safe to use in humans with few mild to moderate GI side effects reported. So that was a lot of information. So let's just summarize all of this in a nice little kind of table. Tecovirimat is essentially first-line therapy for treatment for patients with severe complications or at risk for developing severe complications from monkeypox. It's currently only obtainable if provided by the CDC. PRC and/or the provider must reach out to the national stockpile to obtain the medication. Cidofovir is used only when tecovirimat is not available. It's currently used for CMV and is available at UW through UW. It's also available through the national stockpile if not available at UW. Brincidofovir, as much as it's a great medication, it is not available through the national stockpile yet. The CDC is currently developing an extended access IND approval through the FDA. So then after we know this and we are considering treatment, so after we know that they've been exposed and we're considering treatment, it does take up to 21 days for the virus to incubate and for symptoms to typically onset. So self-monitoring at home with supportive cares is recommended. The CDC does recommend them to isolate at home too, because the monkeypox is contagious, and they recommend isolation all the way until your symptoms have resolved, which means isolation can be 2 to 4 weeks. So when isolating, here are some kind of rule of thumbs. Isolate away from other individuals in your household, no skin-to-skin contact, cover lesions if you need to leave your house for any reason, and wear a mask to avoid that respiratory transmission, and do not share items and avoid large crowds. All right, back to the case. Ted now got tested for monkeypox. His PCR test came back positive. His past medical history now includes CKD stage 4, type 2 diabetes, and anxiety. What do you recommend for him? Do we test Ted again for monkeypox, treat with cidofovir, or start supportive cares for Ted, or tell Ted it's not monkeypox still and to discharge him home? If you could put your answers in the chat, that would be great. I'm seeing a lot of C's in the chat, which is the right answer. So C, the answer is to support Ted to provide him supportive cares. He is a mild case because he's not having any systemic symptoms other. He's just having that rash. So medication therapies is not necessarily indicated for him. We've preserved medication therapies for more of those severe cases. So then leads to my last objective, which is evaluate when vaccine prophylaxis is indicated. So vaccines are currently indicated for high risk and intermediate risk exposures. High risk exposure is specific to a patient who has had sexual partner in the past 14 days with someone who has been diagnosed with monkeypox, multiple sexual partners in the past 14 days in an area with known monkeypox. Intermediate risk exposure is for anyone who has had unprotected contact through bathing, dressing, or transferring. Other exposures outside of this may not be indicated for a vaccine. There are two different types of vaccine. We have ACAM2000 and JYNNEOS. We're going to start with ACAM2000. ACAM2000 is a live replication competent poxvirus strains that can cause clinical infection in humans and transmit it to others. Effectiveness for ACAM2000 against monkeypox is specifically unknown, but there was one study performed in Zaire, which is the Democratic Republic of the Congo. They looked at 2,278 patients during the years of 1981 to 1986 who had close contact with 245 monkeypox patients. 338 patients were infected with monkeypox virus, and 43 of them were vaccinated with the smallpox vaccine. Patients vaccinated had less risk of symptom development at 0.96% compared to the unvaccinated at 7.47. And that was found statistically significant at a p-value of less than 0.001. Adverse events that occurred during include mild pericarditis at about 5.7 per 1,000 patients with a unknown mechanism. Later on, ACIP did review a 2018 study and found that ACAM2000 booster doses were best achieved at 3 years for high-risk individuals and every 10 years for intermediate risk individuals. And then with this study, ACAM2000 was FDA approved for use against orthopoxvirus since 1980 and was recently recommended as routine use since 2015 for anyone born before 1971. Something special about ACAM2000 is that you do give it percutaneously using a bifurcated needle by multiple puncture technique with a single dose, with each dose. So you give 15 jabs essentially to the arm for an intradermal injection. There's a risk for inoculation and auto-inoculation, so this technique needs special training. This major cutaneous reaction, also known as a take, which is the picture to the right, was also used as a marker to indicate successful vaccination. So to kind of summarize ACAM2000, it is efficacious against monkeypox. Booster doses, or it is efficacious against monkeypox virus is possible with ACAM2000. Booster doses every 3 years for patients with high risk, or booster doses for every 10 years for moderate risk orthopox virus is recommended to keep up with immunity. And then mild pericarditis was a severe adverse event reported after ACAM2000 vaccine. Moving on to JYNNEOS, this is a replication deficient poxvirus strain that is not live, and it does not produce infectious virus in humans or typically transmit it to someone else, causing clinical infection. And it does hold a lower risk for adverse events, which we'll talk about. The great part of JYNNEOS is that they don't have that major cutaneous reaction like ACAM2000. So looking at the studies, though, JYNNEOS was reviewed where there are 15 observational studies with a total of 5,775 subjects who received the primary series of the vaccine. They looked at the geometric mean titers and seroconversion data and found that there was a small increase in disease prevention compared to ACAM2000 with fewer side effects. They also looked at when to boost someone after completing their series. So they looked at 17 observational studies with a total of 6,417 patients who received the booster vaccine. The study gave the vaccine every 2 years for high-risk individuals and then 10 years for moderate-risk individuals. And then they looked at the geometric mean and titer and seroconversion rates and found that there was a small increase in disease prevention and few side effects. So overall, indicating JYNNEOS is a safe and effective medication, and this data was extrapolated to be used for monkeypox prevention. It's important to talk about administration because with the need for more vaccine right now, there is a difference between the sub-Q and ID route. It is FDA approved as a 0.5 ml sub-Q dose every with 2 doses, 28 days apart. An alternate route was approved to give the vaccine for patients 18 years or older as an intradermal vaccine with a total volume of 0.1 mils following a second dose at 28 days. This would be a fifth of the current recommended dose or FDA approved dose. So why are we doing an intradermal vaccine administration? There was a 2015 study that looked at sub-Q versus ID and found that ID was like intradermal injection with that 0.1 mil dose was non-inferior to the sub-Q dose of 0.5 milliliters. But however, side effects from the intradermal injection had more injection site reactions than the sub-Q route. But the real answer to why we're just even trying to look at intradermal use for JYNNEOS is due to the scarce supply of JYNNEOS vaccine. So on August 9th this year, the FDA issued an EUA to use the intradermal injection doses as an alternative to sub-Q for only patients that are 18 years or older. Monkeypox is becoming more widely spread, so intradermal injections may be considered to help with extending the supply. UW Health is only doing the intradermal dose and only considering the sub-Q dose for anyone with concerns for dermatologic complications or if they are under 18. And then there are local site injection reactions listed here. We've got mainly redness, pain, and induration, swelling, and itching. Systemic reactions include muscle pain, headache, fatigue, nausea, and chills. And some reactions are lasting up to weeks after the injection. Interestingly, Jill did tell me that they had someone that had a rash that was indented and red for weeks after the vaccine. The best picture I could find is that bottom image there with like an indented kind of injection site reaction to kind of give you perspective. And then the JYNNEOS vaccine overall is just as effective as ACAM2000. Booster doses are recommended every 2 years for patients at high risk and every 10 years for patients with moderate risk. And the nice thing about JYNNEOS is there's no major cutaneous reaction like ACAM2000, but there still are some cutaneous reactions that we should be aware about. Some contraindications to the vaccine include atopic dermatitis, which include JYNNEOS, immunosuppression, which is due to the decreased immune response because of their immunocompromised state. Pregnancy, although there is not evidence to really, not enough evidence to say that it's harmful, but it's just contraindicated. Animal models did show there's no harm to the developing fetus. And then specifically the FDA label and the package insert does say anyone under 1 year for ACAM2000. And then with the expanded EUA, anyone under 18 would get the sub-Q dose, and then anyone 18 or older could get the ID dose. And then with that mild pericarditis concern, anyone with any underlying heart disease is also contraindicated. You could consider giving them JYNNEOS with a cardiologist or a consultation with their provider. So there is post-exposure prophylaxis where there's known monkeypox virus exposure either through tracking, contact tracing, or case investigation. So there's, and then this would be typically best achieved within 4 days. There's also the expanded post-exposure prophylaxis for anyone with known monkeypox exposure with recent sex partner diagnosed with monkeypox within the past 14 days or intercourse within the past 14 days with multiple partners, such as group sex or sex at commercial venue or events or geographic areas where transmission is high. There's unfortunately no current guidance if you are able to give the vaccines with other routine vaccines though. Moving on to my kind of like last vaccine related item would be the immune globulin or Vaccinia immune globulin. There is data to support the use of this for post-exposure prophylaxis. Vaccinia virus is part of the same genus as orthopox virus with similar DNA to smallpox. This vaccine is also stored in the strategic national stockpile requiring approval from the CDC for use. It is reserved for use when the vaccine is unavailable or when there have been adverse reactions that are secondary to continued Vaccinia virus replication after vaccination. So then what exactly does this mean? It's typically for someone who has had eczema vaccinatum, which is a painful rash, fever or facial edema, progressive vaccinia, which is painful or painless, progressive necrosis and ulceration at the injection site from the vaccine, or vaccinia infections in moderate to severe skin conditions such as eczema, lesions, poison ivy, shingles, burns, and infections caused by the vaccine too. Overall, to kind of give you an idea of vaccine availability, ACAM2000 has a large supply available in the US, according to the CDC, although I couldn't find a distinct number reported. JYNNEOS does have a low supply with suggestions to prioritize patients at high risk or patients who could not tolerate the ACAM2000 vaccine. If there is a low supply of JYNNEOS, why are we using it? This is due to a few reasons, though. There are three main ones that I could think of with Jill. It would require that the vaccinators obtain extra training to administer ACAM2000 because it is a skilled technique to use that bifurcated needle. And then we've also got ACAM2000 is a live vaccine and JYNNEOS is not. And side effects for JYNNEOS makes it just overall a preferable option for patients. And then there is Vaccinia immune globulin available, but it's solely restricted by the national stockpile. And then in this scenario in which a patient does qualify for the vaccine, here are the locations that are currently available for the vaccine. When calling the clinics, they will screen the patient for eligibility and schedule a vaccine. Do note that we do list the emergency department, but the current workflow is being in progress. Another location that you could always refer people to is also the Dane County Public Health Center too. And then our formulary and only agent available is the JYNNEOS vaccine. So it only should be ordered if our patients are eligible and are in the locations of Westtown Urgent Care, HIV ID Clinic, and then the emergency department. And if you are able to order both the sub-Q and the ID route, but make sure to double check that the dose is appropriate for their age and indications. Wrapping up Ted Mosby's case for today. Now Ted we know he's positive for monkeypox. He has monkeypox. He's asking about the vaccine and would like to know if he's eligible. With the information you learn, what is Ted eligible to obtain through UW? We've got intradermal ACAM2000, intradermal JYNNEOS vaccine, and then we've got intravenous Vaccinia immune globulin, oral Tecovirimat, or intravenous cidofovir. You can put the answer in the chat box. I am seeing a trickle of B's in the chat box, and yes, that is the right answer. Intradermal JYNNEOS vaccine, that's the only agent that is formulary in our at our institute. Now, just to wrap up the last few minutes, now that we know all about the vaccines, I do want to just talk about pre-exposure prophylaxis. So this is essentially prevention. Biggest thing is to wash our hands. We do a great job with that at the hospital, but always remember, don't forget to do that and encourage your patients to avoid skin contact with people who have rashes that look like monkeypox. Do not share objects, materials with a person with monkeypox or suspected monkeypox. And then when traveling, avoid contact with animals. I know some of them are super cute, but try to avoid those contact with animals, specifically rodents and primates. Vaccines are specific to for patients who work at high-risk areas for exposure, which are typically those with occupational exposure, or for patients traveling or expecting to travel from to and from high-risk areas. UW does have guidance on this too. I just kind of copied and pasted UW's guidance on this. So you can see here, you can look it up too, easily available. They did say that the vaccine is available starting August 29th. So just, I wanted the biggest thing for time's sake to highlight here is that UW does recommend, or you can get the vaccine too if you are expecting to experience any of the exposures to monkeypox, if you are expecting any of the kind of the things listed right there. So I'll let you read that on your own time. It's kind of a repeat from what I've said earlier, but essentially contact through like sexual intercourse or from someone who has suspected monkeypox. And that about wraps up my presentation. I hope you learned lots of cool things about monkeypox, and I'm open to answering any questions you may have.
Hey, can you guys hear me?
Yes, we can.
Thanks a lot for the presentation. This was like super interesting and informative. You mentioned high risk like areas a couple times. Do you know if there is like a graph on CDC website or anything like that that defines those areas, or is it like that chart that you had up a couple times? Any more information on how that's defined?
Yeah. I actually don't know how it's been defined as like high risk specifically. I think it was just based off like kind of the data of transmission rates at the point. But it is something interesting. So like this graph just kind of shows that like if you're going to an area with a lot of cases essentially, but I guess I wouldn't know what would be considered, like high risk. It's a good question though.
Okay, thanks. I suspect that's why the UW criteria avoided that definition.
Mm-hmm. Yeah. I don't think I saw that at all now that I think about, all the review I've been doing on this. Yeah. Good question.